Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. I'm not a cardiologist. Today we'll be discussing on one of the very interesting topic among valvular heart disease we call aortic incompetence or aortic regurgitation. Now, by and large, the common word utilized is regurgitation rather than incompetence. We'll be discussing under these common headings as usual. So, by definition, when aortic valve does not close completely during ventricular diastole, because normally during ventricular diastole aortic valve closes, so blood from aorta cannot regurgitate back into left ventricle. But in this disorder, aortic valve cannot close completely, so it is incompetent. That's why incompetence word was utilized. But now, as the blood is coming back into left ventricle, that's why the word utilizes aortic regurgitation. Normally, blood which goes from ventricle into aorta during ventricular systole but cannot regurgitate back into left ventricle during ventricular diastole because the aortic valve will close completely. Hence, this is called as aortic regurgitation. As far as subclassification is concerned or different terminology is concerned, it is divided into acute and chronic. Second is etiological classification. Third, severity wise, mild, moderate and severe. Etiological wise, the most common rheumatic heart disease, or we call as a chronic rheumatic valvular heart disease because it is a chronic complication of rheumatic fever. Syphilis, nowadays we don't come across syphilis because there is a good treatment available for syphilis. Usually it will come in tertiary stage of syphilis. Another very common, which is an acquired group like infective endocarditis, which will destroy the aortic wall and produce acute aortic regurgitation following a surgical repair of aortic valve like aortic valve replacement or valvoplasty, etc. Very rare, not common, but while doing a procedures which produces a trauma like catheterization, left heart catheterization, angiography, etc. Congenital aortic regurgitations are not very common, but it can be there in some of the disorders like Marfan syndromes, Ehlers-Danlos, etc. And once in a while in case of an SLE. So this is indirectly the etiological classification, or we can call as a etiology. Acute is most common in infective endocarditis, post-surgical, post-trauma, dissecting aortic aneurysms, etc. While chronic variety we call as a chronic rheumatic valvular heart disease. It may be there along with mitral stenosis or with mitral regurgitation. So among etiology, congenital and acquired. In congenital, it can be with bicuspid aortic valve or normal tricuspid aortic valve. It is very frequently associated with some of the congenital collagen disorders like Marfan syndromes, Ehlers-Danlos, osteogenesis imperfecta, pseudoxanthoma elasticum, cystic medial necrosis, all these conditions where collagen tissue formation is abnormal, and then that can end up with mitral valve involvement or aortic valve involvement, quite common. Among acquired, that is much more common than congenital variety. Among acquired rheumatic heart disease, that is as a chronic complication of rheumatic heart disease, invariably it is always associated with mitral valve involvement. In severe systemic hypertension, along with dilated aorta, degenerative disorders, connective tissue disorders like ankylosing spondylitis, rheumatoid arthritis, Ritter's, giant cells arthritis, etc. Syphilis and aortic incompetence in aortic dissection like dissection of aorta or aortic aneurysms, infective endocarditis, post-traumatic and post-surgical, particularly valvuloplasty or aortic valve replacement, AVR. So the most common is rheumatic heart disease. About 2/3 may be associated with aortic stenosis and or with mitral valvular disease. Infective endocarditis, congenital bicuspid valve, and collagen tissue malformation like Marfan's, Ehlers-Danlos, etc. Aortic root dilatation can occur in Marfan syndrome, aortic dissections, syphilitic aortitis. Leaflet involvement, very typical in rheumatic fever. Endocarditis, traumatic injury, bicuspid aortic valve, rheumatoid arthritis, myxomatous degeneration, ankylosing spondylitis, even in acromegaly. While root involvement, where you get dilatation of the root producing aortic regurgitation, in systemic hypertension, syphilis, reactive arthritis, ankylosing spondylitis, traumatic injury, dissecting aneurysm, osteogenesis imperfecta, Marfan's, Ehlers-Danlos, even in IBD, inflammatory bowel disease. These are all rare conditions, not very common. We already mentioned regarding acute and chronic previously. This is repetition. In acute, most common post-traumatic aortic dissection, infective endocarditis, and post-surgical. While in chronic, bicuspid aortic valve, rheumatic, SLE, degenerative, aortic root dilatation like in hypertension, syphilitic aortitis, Takayasu, giant cell arthritis, rheumatoid arthritis, Whipple's disease, ankylosing spondylitis, connective tissue like Marfan's, Ehlers-Danlos, floppy aortic valve prolapse, etc. Now this is what is going to happen. So in a pathophysiology, we'll divide into two big groups, acute AR and chronic AR. So to understand that, if suddenly the aortic valve become regurgitated, so what happens during ventricular systole? Ventricle contracts, blood will go into aorta during systole, but during diastole, blood will come back into ventricle. And because this is an acute onset, the blood will come back into LV. It will produce sudden ventricular preload. Now here the ventricle doesn't get a chance to compensate by means of dilatation plus hypertrophy. So LV pressure is elevated, left ventricular and diastolic pressure is elevated, which will increase left atrial pressure. Because there is an increase in left atrial pressure, there will be little dilatation of a left atrium. Pulmonary venous pressure will be elevated, wedge pressure will be elevated, and person will go into acute left ventricular failure. Here, ventricle is not dilated, neither much hypertrophy, because ventricle doesn't get a chance to undergo what we call as a compensation. This is a classical example of acute aortic regurgitation. So person will have a symptom sign suggestive of a left ventricular failure like pulmonary congestion, pulmonary edema, which will end up with central cyanosis, severe hypoxia, and then later on person can also develop right side failure, we call congestive cardiac failure. Mixed together we call congestive heart failure. While what happens in a chronic variety, or we call as a mild variety, because of mild regurgitation, there is a small quantity of a blood which is coming back into ventricle. So in a ventricle there is a volume overload. Ventricle tries to compensate. In compensation it undergoes dilatation plus hypertrophy. So there is a gradual dilatation plus hypertrophy. So ventricle volume is increased and diastolic volume is increased. There is a increased size of left ventricle as well as hypertrophy of left ventricle. So it is dilatation plus hypertrophy. Secondary to this, there will be cardiomegaly, there will be heaving type of apex beat, person will have a palpitation. Now all this blood during systole, more quantity of blood which is going to aorta, good quantity of blood is coming back to left ventricle during diastole from aorta because of regurgitation. So now slowly over a period of time, left ventricular pressure is elevated. That will have effect on a left atrial pressure. So you will have a slowly dilatation plus hypertrophy of left atrium. This can produce a pressure effect on surrounding structures like esophagus, trachea and left recurrent laryngeal nerve. Also there will be gradual increase in the left atrial pressure which will have effect on a pulmonary vasculature. Pulmonary venous congestion will take place. There will be pulmonary hypertension. Secondary to pulmonary hypertension, now right ventricle will be affected. So in the right ventricle you will start getting pressure changes. Right ventricle will undergo hypertrophy. Right ventricular and diastolic pressure will be also elevated. Right ventricle has to do more work against pulmonary hypertension. Right atrial pressure elevation, and in the late stages, person will have a pressure elevation in superior vena cava and inferior vena cava. We'll call that as a right side failure, or we'll use the word congestive cardiac failure. This is common in chronic rheumatic valvular heart disease, which is of a mild variety, not severe variety. If it is severe, by and large severe are all acute. And classical example of an acute is infective endocarditis, post-traumatic, post-surgical, or because of aortic dissection, aortic aneurysm dissection, etc. These are the common conditions which will produce acute AR, and they are usually severe variety. So this is what is going to happen in chronic because of aortic regurgitation. Left ventricular volume is increased, LV size will increase, and diastolic pressure will be elevated. Because there is an increase in end diastolic pressure, there is a dilatation with hypertrophy. During ventricular systole, there is a good cardiac output because the end diastolic volume is increased. So that will produce large pulse volume, or we call as systolic pressure will be elevated. During regurgitation, the diastolic pressure falls tremendously, and that will produce a wide pulse pressure, which will have classical all peripheral pulse signs. We call as a, there are many different signs which are being named, but classical we always use the word water hammer pulse. Now LV, which is dilated and hypertrophy, there is a slowly overload on the LV. It can undergo decompensation and can produce a left ventricular failure where ejection fraction will be reduced and left ventricular and systolic volume will increase. This will what will happen in a decompensated stage. but this will happen in mild to severe variety. In acute, we have already explained that because of an acute AR, left ventricular volume is sharply increased, left ventricular diastolic pressure will be increased, left atrial pressure will be increased, pulmonary congestion, pulmonary edema, and because of this, good quantity of blood is coming back into LV, so that produces decrease in cardiac output because of an acute AR. So that will produce fall in diastolic pressure, increase in systolic pressure, and will end up finally with left ventricular failure, acute left ventricular failure. So we have already explained before. Going back again, diastolic regurgitation will have increased LV volume, increase in stroke volume because now LV and diastolic volume is markedly elevated, decrease in aortic diastolic pressure, so diastolic pressure good number of time may be close to zero, decrease in effective stroke volume. Now secondary to increase in volume, there is a dilatation plus hypertrophy, so there is dilatation plus hypertrophy, LV dysfunction, because secondary to LV dysfunction, LV failure can occur, and diastolic pressure is elevated, which will produce dyspnea. Myocardial oxygen consumption will increase because of increased LV mass, that will produce myocardial ischemia, and that can also end up with LV failure. And because of ischemia, you can have a and diastolic pressure being elevated, and person can complain of dyspnea. Because of increased stroke volume, systolic pressure is elevated and diastolic pressure will be falling, so there will be wide pulse pressure. And because of decreased diastolic pressure, decreased filling in the coronary artery, as well as increased demand because of the LV mass increase, results into myocardial ischemia, and all that can exaggerate left ventricular failure. We already explained you in an acute AR what is happening. At your leisure time, you can go through. This will be very fast in acute aortic regurgitation. LV doesn't get a chance to compensate. So here, left ventricle doesn't get a chance to compensate. Before that, all the changes will take place. Person will develop cardiogenic shock because of decreased systolic volume or stroke volume we call, and cardiac output will drop, and person will now develop angina because of decreased coronary perfusion, and there will be a sharp elevation in LV and diastolic pressure, which will have an increase in left atrial pressure and will end into acute pulmonary edema. This will what will happen, compensation will be there initially by means of dilatation plus hypertrophy. When that fails, person will go into decompensation, and secondary to decompensation, there will be further ventricular dilatation, increase in demand, myocardial ischemia, contractile dysfunction, decrease in ejection fraction, decrease in stroke volume, decrease in cardiac output, congestive heart failure symptoms will start. You can have effect both on left ventricle as well as right ventricle, and because of decreased perfusion, angina, etc. will take place. This already we have explained in previous. At your leisure time, you can go through how exactly that happens. We have shown you lot many. This is the thing, classical, same thing is repeated here. So backflow, left ventricular hypertrophy plus dilatation, left side heart failure, decreased cardiac output, left atrial pressure is elevated, left atrial hypertrophy, increased pulmonary pressure, and right ventricular pressure elevation, and you can have right side heart failure. These changes will take place if there is a mild, very mild aortic regurgitation, and which is chronic variety. Acute will never be a mild aortic incompetence. By and large, it is severe. In severe, this will happen very fast. This changes. Decompensation will happen very fast. This is what is happening during a ventricular diastole. The blood will regurgitate. That blood will have effect on anterior mitral valve leaflet, which will flutter, which will produce a sound which we call as Austin Flint murmur, or because of blood which strikes on anterior mitral valve leaflet produces relative mitral stenosis. There is no mitral valve involvement, but that can also produce a sound at mitral valve origin during left atrial systole, producing a mid diastolic murmur, and that is called as a Austin Flint murmur. We'll be talking further. Now, as we go to clinical features, mild variety will be usually asymptomatic unless he goes to fourth and fifth decade. Rate of progress is very slow, usually in a mild. In a variety of acute, you can have an acute onset of all symptom signs suggestive of a left ventricular failure. The commonest symptoms we call triad, that is dyspnea, nocturnal angina, and palpitation. Dyspnea can be exertional dyspnea in a left ventricular failure, PND, and orthopnea is common. Nocturnal angina is common because during night there is a decrease in the heart rate, reduction in the diastolic blood pressure, and that will produce decreased perfusion to the myocardium, and person can get anginal episodes, and that's why the name given is nocturnal angina. Palpitation is very common because of increased size of left ventricle, dilatation plus hypertrophy. So there is dilatation plus hypertrophy, so there is an increased force of contraction. So these are some of the common symptoms in early stages. And as the person advances, in a mild variety, person will develop congestive cardiac failure, or we call a right ventricular failure, where person will complain of edema, puffiness, JVP elevated, distension of abdomen, hepatosplenomegaly, etc. While in case of a left-sided failure, exertional dyspnea, orthopnea, PND, and person will have a basal crackles, etc. Central cyanosis, severe hypoxia, blood stained frothy sputum. So dyspnea, palpitation, and angina becomes topmost on the list, and particularly we call nocturnal angina. In cardiovascular system examination, in a mild to moderate variety, there is a gradual dilatation of left ventricle, so it will produce cardiomegaly. Apical impulse will be downwards and outwards. Good number of time it is in a mid axillary line or a posterior axillary line. Increased cardiac dullness, boot shaped heart, increased cardiac size. Diastolic murmur we call as early diastolic murmur in aortic area. Also early diastolic murmur is also heard in mitral area, which is we call as Austin Flint murmur, which is not because of mitral stenosis, but it is because of little decrease in the diameter of a mitral valve opening because of effect of regurgitant flow on an anterior mitral valve leaflet. And good number of times there is another explanation, that is a flutter of anterior mitral valve leaflet. So that will produce what we call as a diastolic murmur. They also say that because of increased blood flow across aortic valve during systole, it will produce ejection systolic murmur, which is a flow murmur which can occur at aortic valve. We also call that as functional murmur or a flow murmur. So this can be there. Because of LV dilatation, you can even develop a mitral regurgitation, which can produce systolic murmur, which can be also heard in mitral area. So these three will be not involvement of a mitral valve leaflet, but because of LV dilatation, ring dilatation. This is because of effect on an anterior mitral valve leaflet, which will produce relative mitral stenosis. There is no damage to mitral valve leaflets. and flow murmur because of increased blood flow across aortic valve during ventricular systole. So these are all the different findings you can come across. So clinical manifestation, we have already told you, because of hypertrophy and dilatation, palpitations. Person can complain of dyspnea on exertion, tachycardia. Dilatation can also result into premature beats. Because of increased systolic pressure and marked fall in diastolic pressure, there is wide pulse pressure which will produce bounding pulse or large volume pulse. Carotid pulse is markedly large volume, which we call as a Corrigan pulse or dancing carotid. Left ventricular dilatation plus hypertrophy, so there is a good amount of cardiomegaly. Secondary to decompensation, person will complain of exertional dyspnea, nocturnal dyspnea, orthopnea, secondary to left ventricular failure. And we have already mentioned, because of right ventricular failure, person will have a peripheral edema, puffiness, JVP elevated, ascites, hepatosplenomegaly, etc. Because of fall in the diastolic pressure and decrease in the cardiac output, there will be chest pain, and person can have anginal pain more during night because there is even bradycardia. This will produce what we call as a nocturnal angina. And in auscultation, we already told you, because of aortic regurgitation, at aortic valve, you will have early diastolic murmur, blowing murmur, grade 3, usually not radiated to any particular area, well localized, a very soft murmur. It is described as a soft blowing murmur. Already we have explained you this, that in an acute severe aortic regurgitation, you can have tachycardia, central cyanosis, peripheral cyanosis. Peripheral signs of aortic regurgitations, left ventricular impulse will be usually in a normal place. There is not much amount of left ventricular dilatation or hypertrophy, and there is a severe signs of acute left ventricular failure in the form of acute pulmonary edema. So tachycardia, cyanosis, pulmonary edema, basal crackles. Usually by and large we hear a murmur on a aortic area, or we call on a right sternal border. While in a chronic, you will have a marked dilatation of the LV, you will have a exertional dyspnea, orthopnea, paroxysmal dyspnea. Common complaint, we have already told you, dyspnea, nocturnal angina, quite common. On examination, in chronic or acute variety, because of a wide pulse pressure, collapsing pulse, or we call as a water hammer pulse, or a bounding pulse, or a large volume pulse. Blood pressure, systolic pressure will be markedly elevated, diastolic pressure will be very low. Because of that, there is a wide pulse pressure. There are a lot of different signs which we'll be discussing further. We call as a water hammer pulse, Hill sign, main signs, etc. Temperature usually normal. Respiration, person can have tachypnea either because of congestive heart failure or a right ventricular failure or a left ventricular failure. There are good number of pulses which are being described: Corrigan pulse, water hammer pulse, pulsus Bisperians, etc. This is a diagram which is showing you different type of pulse, that you can have a flushing, and flushing disappears, malar flush appears and disappears. It is called as a lighthouse sign. If you press over the nail bed, you get blanching and reddening. So we call nail bed capillary pulsation. That is called Quincke's sign. That is, if you apply a pressure on the nail bed, you will see the blanching takes place, and there is a again appearance of redness, blanching, redness. and that is typically described as King-case signs. Upper limb and lower limb pulsation, if you look at systolic blood pressure in lower limb is greater than upper limb by 20 millimeter of mercury, and if it is more than 20 millimeter we call it a Hill sign. Depending upon the Hill sign, you can even classify them into mild, moderate and severe. We'll be having a further discussion. Because of a large quantity of a blood which is flowing during systole into cranial cavity and during diastole, there is a sudden fall in the blood flow. This will produce a nodding of the head, or we call titubation, or also called as the Alfred de Musset sign. Carotid pulse is bouncing, it is called dancing carotid, or also called as a Corrigan pulse. If you put your stethoscope on a femoral artery, you will get a diastolic murmur because of a blood flow back into aorta during diastole, and also the murmur is also heard during systole. This is called DISEASE murmur. These are some of the common signs which you can easily demonstrate. This is a big list. Quincke's sign we already explained, capillary pulsation in nail bed. Corrigan's sign is also called as a water hammer pulse or collapsing pulse, or also there was another person who described that pulse was Watson. So it is also called as a Watson pulse. If you palpate a pulse, if a person has got a severe AR or AS with AR, it is called described as a Bispherians pulse. Nodding of the head or bobbing of the head, also called titubation, or also described as Alfred de Musset signs. If you ask the person to open the oral cavity, you look at the uvula. Uvula will show you systolic pulsation. Means during systole there will be movement of in the uvula or pulsation in a uvula, called as a Muller's sign. If you examine the carotid pulse, it is a bouncing carotid pulse or dancing carotid pulse or a large volume carotid pulse, or also called as a Corrigan pulse. There are good number of other signs. In a retina you get pulsation called Baker's sign. Liver systolic pulsation is called Rosenberg sign. Enlarged spleen shows a pulsation called Gerard signs. Pupil will show some signs called Ledorf signs. We already told you on a forehead or on the malar you get blanching and flushing, that is called Lighthouse sign. These are some of the many signs: Lincoln signs, Sherman signs. Dorsalis pedis will show you marked pulsation. Popliteal shows Lincoln sign. Dorsalis pedis called Sherman signs. We already told you if you put your stethoscope on a femoral artery, you get bruit during systole as well as diastole, because blood flow forward during systole and backward during diastole, producing a murmur or a bruit. We call it as a DISEASE sign. Some are using S as Z, and in some they use S as a spelling. Trop sign is if you put your hand on the femoral, you get a large bounding pulse, also described as a pistol shot femoral. Hale sign, we have told you, if it is more than difference is more than 20 millimeter, it is mild. More than 40 millimeter difference, it is moderate. And if there is a difference more than 60, it is called severe aortic regurgitation. If you elevate your arm and if there is a drop in a systolic blood pressure by more than 15 millimeter, you call it a main sign. And on auscultation in an mitral area on apex, you get a soft diastolic murmur. It is called Austin Flint murmur. These are all the peripheral signs, out of which some of the signs are very common: Quincke's, Corrigan sign, Bispherians pulse, Alfred de Musset signs, Muller's signs, Corrigan pulse, or we call dancing carotid, DISEASE sign, Trop sign, Hale's sign, main sign. All these are quite common, easily demonstrable. This can be asked to you in your oral quite frequently. So this is very, very important for fourth year student. So do keep it in mind. These are all signs. We have again given a description. What is Alfred de Musset, Muller sign, Baker's sign, Quincke's, DISEASE, Trop signs, Mainz, Hales, Rosenberg, Gerald signs. etc. All those signs. Again, I've got different slides. These are all the different signs. If you are interested, go to your leisure. If you remember, well and good, they are good signs, useful signs. We already mentioned in a chronic AR, or we call it a mild variety. Systolic blood pressure will be elevated, diastolic pressure will be low because of regurgitation. There will be a wide pulse pressure. S1 sound, S2 sound will be affected. S3 will be present in case of congestive heart failure. S4 is usually not present, and this will be typical in a chronic. In an acute, aortic pulse pressure instead of increase might fall suddenly because of acute left ventricular failure. Usually there will be little fall in the heart rate, and S3 will be present. It will be very peculiar in case of an acute, and mainly it will be in the apical region. We call LV, on a LV side. We already given you a description. Site will be aortic area, early diastolic murmur, decrescendo murmur, low pitch, soft, it is called soft blowing murmur, grade 2 or 3, does not radiate, no change with respiration valsalva or any change in the position. There will be an increased flow across the aortic valve producing a ejection systolic murmur, we call it a flow murmur at aorta. And there will be a diastolic murmur at mitral valve, we call it the Austin-Flint murmur, which will be a mid-diastolic murmur. If there is a marked LV dilatation, it can produce even a systolic murmur at mitral ring area, which can be a systolic murmur because of a ring dilatation of mitral valve. All this I have already given a description. Diastolic murmur at aortic area, Austin-Flint murmur at mitral valve, either because of mitral valve flutter or because of relative mitral stenosis. In an aortic area, systolic flow murmur will be heard. Because of LV dilatation, ring dilatation will produce a systolic murmur in mitral area because of relative mitral regurgitation. And there will be a wide pulse pressure, we call it a collapsing pulse. I am skipping over this. At your leisure time, you can go through if there is an associated AS. If aortic stenosis is dominant, then AR. And if AR is dominant, then AS. This will be the minor difference which can be there. If you are interested, you can go through your at leisure time and try to find out. As far as investigation is concerned, there is one investigation which is useful. Chest X-ray, which will show you in a chronic variety, a huge cardiomegaly, boot-shaped heart. Apex will be almost downwards and outwards, close to the anterior axillary line. ECG will show you a huge LV, that is left ventricular hypertrophy. You can have a arrhythmia like atrial flutter fibrillation because of left atrial dilatation. Ectopic ventricular beat can be there. In a case of an acute, ECG may not show you LVH. And in a chest radiology, you will see pulmonary congestion and curly A line, curly B line. But there will be not much amount of cardiomegaly. It will be a mild cardiac enlargement, very, very mild, almost negligible. Echocardiography will help you to differentiate very easily aortic regurgitation because there will be blood flowing back into ventricle during ventricular diastole from aorta into LV. And you will see even a flutter of an anterior mitral valve leaflet, which can be seen in an echo. You can demonstrate severity of aortic regurgitation, the condition of aortic valve, condition of the root of aorta, size of LV, myocardial mass, LA pressure, etc. can be easily seen on an echo. Cardiac catheterization and aortography is needed if a person is subjected to surgery to find out the coronary artery involvement, and also if there is any other associated anomaly, etc. can be easily identified. So these are some of the tests which can be done in aortic regurgitation. So mainly chest X-ray, ECG, echo, and cardiac catheterization. So I've already told you in ECG, you will have a LVH with strain pattern in chronic rather than acute variety. As far as the chest X-ray is concerned, you will have a big dilatation with almost boot-shaped heart and features of left heart failure in the form of pulmonary congestions, curly A line, curly B line. More in case of an acute variety, you will come across a LV failure. And big dilatation you will see more common in a chronic variety rather than an acute variety. Echo, already I have told you, the dilated LV will be more common in chronic rather than acute. You can see fluttering of the anterior mitral valve leaflet, hyperdynamic LV, etc. can be easily seen. You can see the regurgitant flow, severity, site, type of a mitral valve, aortic valve, bicuspid, tricuspid, aortic valve, all those you can identify. And you can detect reflux by doing a colored Doppler. Cardiac catheterization will be useful to find out the severity, dilatation, aneurysm, dissection, uh, coronary artery conditions, the flow in a coronary artery, etc. This is showing you a big dilatation of the aortic, almost aneurysm formation. You can see that aneurysm is formed. So this is almost aneurysm, and that is producing aortic regurgitation. So there is a big LV. You can see this arrow is showing an aneurysm part. So there is LVH with aneurysm, and that is aortic knuckle. This is in a chronic, you can see a big heart, and this is in an acute variety. You can see there is not much amount of cardiomegaly, but there is lot amount of pulmonary congestion. Here there is no much amount of pulmonary congestion. There is a big heart. So that is a difference. In ECG, you can see LVH with strain pattern, quite common. At your leisure time, you can go through echo changes in mild, moderate, and severe variety. What are the changes in left ventricular size, Doppler, colored Doppler, quantitative estimation, etc. If you are interested, you can go through. These are the pressure gradients, angiographic grades, Doppler, then regurgitant volume, regurgitant fraction, etc. in mild, moderate, and severe. So these are echocardiography findings and angiography findings. As far as differentiation is concerned, you will have to find the etiology, whether it is rheumatic, syphilitic, because of root dilatations, aneurysm, dissection, post-surgical or post-traumatic, infective endocarditis, etc. all can be identified. And you should try to differentiate whether acute or chronic, etc. As far as treatment is concerned, one of the treatment is infective endocarditis prophylaxis. Should be given in any person who has got an aortic valve involvement, or even if there is a prosthetic valve replacement, you must give infective endocarditis prophylaxis. As far as medical treatment is concerned, in presence of congestive heart failure or a left ventricular failure, vasodilators in the form of ACE inhibitors, nifedipine can be also used to reduce what we call as resistance and improve the stroke volume. For a regular follow-up and for monitoring the progression, regular checkup as far as echo should be done. And if a person has got moderate to severe variety and person is going into decompensation, after controlling the failure part, he should be subjected to surgical intervention. And almost all person with aortic valve involvement should be receiving infective endocarditis prophylaxis. As far as surgical treatment is concerned, there are different ways in which the surgical treatment is given. We'll be just showing you the slide in the next. So in an acute AR, you will require inotropes to increase your cardiac output because there is a marked fall in cardiac output. Vasodilator you will require. You will have to avoid beta blocker that will further reduce your cardiac output. So do not give beta blocker in acute AR. This is what algorithm you proceed in a severe aortic regurgitation. Any person who has got a severe aortic regurgitation, first is confirm the diagnosis and treat for the failure. Once the failure part is controlled, you can go for aortic valve replacement. Main surgical intervention has to be done. So these are the indication for aortic valve replacement. I am not going into detail regarding those indications, class 1 and class 2 indications. There are two types of surgery which are being done. One is open. You open up the chest by doing a sternum is split, and then you can proceed to the aortic root. You can do annuloplasty and valve repair or replace the valve. So this is annuloplasty which is being done, and then you replace the aortic valve with a synthetic valve, prosthetic valve. Now there are bioprosthetic valve which are available. This is very rarely required. This will be very commonly required in an aortic root dissection, aortic root dilatation, or in a person with aortic aneurysm with dissection, etc. In those conditions, this will be the best procedure. We call reconstruction of aortic root with valve replacement. These are the different types of valve which can be utilized, right from metallic valve to synthetic valve and bioprosthetic valve. Now after the availability of the bioprosthetic valve, the complication chances has reduced remarkably. And in a person where you replace the aortic valve, you can replace it by different procedures. And there is one procedure which is called as a catheter valve, catheter, via catheter, transaortic valve replacement, or it is also called as a TAVI, transcatheter or transaortic valve implant. So that is called TAVI. So these are different procedures which are being there. Complication of aortic regurgitation in an acute AR. You can have an acute LVF and the prognosis is poor unless diagnosed early and treated early. In a chronic and mild variety, usually person goes into right ventricular failure, we call congestive cardiac failure. Infective endocarditis is quite common. In a person with syphilitic ostial stenosis and also in case of a chronic AR, person can have a nocturnal angina. Because of a big left atrial dilatation, in some of the condition you can have atrial flutter fibrillation and thromboembolic phenomena. And because of pressure on esophagus, trachea, left trachea, what we call, sorry, not left trachea, left bronchus, esophagus producing dysphagia, compression on the left main bronchus producing hemoptysis and collapse of the left lung. And also it can produce a left recurrent laryngeal nerve palsy producing hoarseness of voice, and that is called Ortner syndrome. As far as arrhythmia is concerned, ventricular premature beats, and because of a big LA, you can have atrial flutter fibrillations. And in acute AR, the chances of complications are very high and mortality is also high. Person can get death. So I end my lecture here. I hope this is helpful to you. See you in the next lecture on another valvular heart disease.